Hi, I'm Dr. Kenneth Adams from Pentucket Medical Associates, and I'm happy to be hosting another episode of Matters of the Heart. This is brought to you by Pentucket Medical Associates and Haverhill Community TV. I'm very happy to have Dr. Isaac Pourati with us today. Dr. Pourati brings a new cardiac specialty to the Merrimack Valley. He's an electrophysiologist, and today he's going to speak with us about evaluation of palpitations.
Hi, thanks for having me.
Oh, you're very welcome.
So this is going to be an open discussion here. My specialty is electricity of the heart. I would like to think of a heart as a pump. So it has plumbing and it has electricity. The plumbing is where the heart attacks are, the blockages and all that. And electricity is dealing with fast beats, slow beats, extra beats, that kind of stuff. So my specialty is that. And the heart has a pacemaker. The pacemaker tells the heart when to beat, how fast to beat. When you're sitting down, it's slow and regular. When you exercise, in order for your heart to pump enough blood to your body, the pacemaker makes your heart beat faster. And so my typical patients are the patients who have these abnormalities of the heart rhythm. Either the heart is beating too slow, or it's beating too fast, or it's beating irregular. They're having extra beats.
So let's just take a clinical example. Suppose a 45-year-old woman who's generally pretty healthy comes into your office, and she's there because intermittently, even without activity, she all of a sudden feels her heart going really fast. So what would be your evaluation of her? What would be your concerns about her and her clinical problem?
I see that very commonly. And so I have a few things I do. First, I talk to them for half an hour to find out how often it happens, when it started, if they have any other symptoms like shortness of breath or chest pain. Then my initial goal is to determine if that's something dangerous or benign.
And how would you figure that out? How can you tell if it's something they need to worry about or not worry about?
The bottom line is, if you have a normal heart, you never had a heart attack, your heart is beating strong, then chances are the fast heartbeat is not dangerous, it's benign. It's true, it's there, and it causes very bad, severe symptoms, but unlikely to kill you. And we have our ways to determine that. One is the electrocardiogram. That's the EKG with the wires. That's one test. Mm-hmm. And most commonly, we also do an echocardiogram. That's the ultrasound of the heart. It's the same machine that you look at the babies and pregnant women. We have the same one for the heart. And that looks for the heart function, the pumping function, looks at the valves. And if those tests are normal, then that by definition means you have a normal heart, and the fast beats are not something that you should worry about being fatal, basically. Okay.
So you can give some reassurance if you have
Yes.
a good-looking electrocardiogram and a good-looking cardiac ultrasound.
Yeah.
And then what would be your next move to try to figure out what kind of, because you and I know that there's lots of different types of heartbeats that cause that sensation of palpitation. So what might you do next to try to figure out what's actually happening?
Excellent question. Okay, so my first goal was to determine if it's dangerous or not. Once we take that out of the question, then the second question is, how bad are the symptoms? If the symptoms are mild, sometimes I reassure the patients, sometimes it's anxiety, and I don't do any further testing if there's mild symptoms. If they have severe symptoms, then it could be one of many things. The most common fast beat is your own heart beating fast from other things. For example, anxiety. Or in women who are nearing menopause, it would be hormonal changes. Then sometimes there is some other sickness. For example, there's an infection in the body. And from the stress of that infection, the heart beats faster. And those things, there is no treatment for other than reversing what caused it. For example, if there's an infection, you treat the infection, or anxiety and so forth. The other things are abnormal heartbeats, and those are fast beats that are because of an electrical problem in the heart. The thermostat is off. It's supposed to beat 60, but it's beating 120. And that kind of abnormality versus the normal heartbeat going fast, we have a test to differentiate between those two. And that's a test, it's called a monitor, a Holter monitor. You go home with a pager size device, two wires come out, and you stick them on your chest. You go home with this, and this records the rhythm when you have the symptoms. What ends up happening is that when the patient has the symptoms, they click it. Oops. Okay. And that records the EKG, and it comes on my desk, and I look at it, and I determine what it was.
Right. So we have that Holter monitor, which usually might be 24 hours,
Yep.
and then I think you were also describing these longer monitors, like an event monitor,
Right.
where a patient can actually push a button and record it when they get that feeling of palpitations.
Yes.
So the other thing I was going to ask you is, you mentioned symptoms. So what might be some of the symptoms that people get if their palpitations are severe enough?
When your heart beats very fast, unfortunately, it becomes inefficient because the pump is beating so fast that it doesn't have time to open to beat the next one. So the fast heartbeat and the inefficient heart from the fast heartbeat, it can cause chest pain, almost like a heart attack. It can cause fainting spells. And sometimes it mimics an anxiety attack. People feel like they're in doom. In fact, what they have is that the heart is beating fast from that abnormal electricity. So it's hard to differentiate between them by the symptoms. You have to have the tests to figure that out. And some people even seize when they faint. They start having seizures. So that's a minority of patients that present with seizures. Most common is palpitations.
Okay, so a lot of these, you've talked about sort of the electrical system in the heart and saying a lot of the times the palpitations do just because the electrical system is acting the way it's supposed to, or maybe sometimes there's a short circuit in the rhythm and they're getting some abnormal beats. Can you tell us or describe, because there's some abnormal beats that are really not too worrisome if they come from the top of the heart, and others that might be a little more worrisome if they come from the bottom of the heart. Maybe you could explain that a little bit.
So, excellent question. So the whole point of seeing me or your own cardiologist is we are trying to find out if this thing that's causing your heart to race, is that something dangerous or not? That's the first step. And so most commonly the dangerous ones are originating from the bottom of the heart. We call them from ventricles of the heart. And those are associated with heart disease. So either some people know they have heart disease, coronary disease, a blockage, or they don't know it yet. And we are just diagnosing it by doing the tests. And those things, most often we figure them out by the test we did, either by the electrocardiogram or by the echocardiogram, the ultrasound, or by the one that you take home. So if we find that you have one of those dangerous ones, the whole treatment is different. And it's beyond the discussions of this study. If you have that dangerous arrhythmia, you'll have to see me more often, and we'll have to do, we go to a different branch of treatment.
Let me ask a question about something that might illustrate some of the things that you do for patients in terms of treatment. I just saw a patient in my office today who has something called WPW, or Wolff-Parkinson-White syndrome. And I know sometimes that's treated with a procedure. But I wonder if you could explain what that is for our audience.
Okay. So one of the reasons the heart beats fast is because there's a short circuit in the electricity of the heart. And where the normal pacemaker, it's beating 60 beats a minute, and suddenly one of these electrical circuits of the heart, they short circuit and they go in a loop. And that loop, every time the loop goes around, it makes the heart beat once. And that can cause very fast beats. So WPW, that Wolff-Parkinson-White syndrome, is one of those short circuits. It's one of those. And what the name comes from is that you can actually see the short circuit on an EKG. So you can go to your doctor for a routine visit, and they do an EKG, and they say, this EKG doesn't look normal. And that EKG can indicate that your heart has that short circuit. And if you have that EKG abnormality, and you have racing heartbeats, I or people in my specialty, we can actually go into the heart with catheters and zap the short circuit, hence preventing that fast beat and curing it, basically, from happening again.
Right, right. And that falls into the whole classification of treatments called ablation.
Yeah.
So where you're actually going in and ablating or interrupting an electrical pathway. But is that WPW something that's common? I think there's another one that's more common.
The most common cause of fast beat that's from the short circuit, it's called AV node reentrant tachycardia. It's some part of the heart that's we know which ones are more common and less common. From the standpoint of the viewers, it probably doesn't matter.
Probably similar symptoms.
Yeah, the symptoms are similar. But we'll figure them out by looking at the electrocardiogram and EKGs and all.
Okay. Are there any lifestyle changes you might recommend if somebody has palpitations? For example, caffeine intake.
That's a good point. So, yes, caffeine, alcohol, those are and stress, either emotional or other kinds of stress. What happens with those things is that the short circuit in the heart, it's affected by hormones in the blood. And one of the hormones we have is adrenaline. And so if you get stressed out, that hormone goes into your bloodstream and it affects the heart, the conduction of the heart. And that can trigger the fast beats.
Right.
So why doesn't it happen to everybody when you get angry or mad and you have a fight? How come you don't go into that arrhythmia? Is because not everybody has the short circuit. The short circuit is only a minority of people have it. So if you have that short circuit and you have the trigger combined, that can put you in the fast beat.
Okay. And another question I had for you. So we've talked about some patients who might have sort of a minor problem with palpitations and perhaps a lifestyle change and making sure that their heart's otherwise okay, and reassurance might help. But what are some of the other treatment strategies? We've talked about no treatment versus that ablation treatment, but what are the kind of things in between?
Okay. When I diagnose a patient with one of those arrhythmias, the fast beats that are benign, the benign fast beats, if they are frequent and if they are bothersome, I usually, especially the young patients, I encourage them to have the ablation. That's because the other options are doing nothing, which is okay if you can tolerate it, or doing medications. And the medications, first of all, are not curative. They can reduce the severity of the symptoms and they can reduce the frequency of events, but oftentimes it comes back. And the other thing is that you have to take the medication every day.
Right.
And if you are a young person, you don't want to be on the medication for the rest of your life. So the ablation is an option that is curative, it's low risk, and usually you come to the hospital in the morning and you go home in the afternoon.
It's something that is gaining a little bit of popularity. I think I wanted to get your view on it, is this so-called pill-in-the-pocket approach, where, maybe you can explain what that means.
Good point. Well, so different physicians have different methods of treating these fast beats. there are some physicians who give the patients the pill to slow down the heart to carry with them. And when the tachycardia, when the fast beat starts, they take the pill to help break it. And that is effective most of the time, but not 100% of the time. Personally, I don't use that strategy.
Okay. When would you encourage a patient with palpitations to seek medical attention? What would be some of the symptoms or signs that you would encourage them to go see their doctor for?
Okay. I would probably, if you have symptoms that are recurrent, I would encourage you to see a doctor no matter what. Just at least to be screened. If you are older, the older you are, the higher the chance that you might have some serious heart disease that you don't know about. So the young athlete, the one who participates in sports, I would probably encourage them also to come earlier, because some of these arrhythmias that are potentially dangerous and potentially deadly, they happen in the athletes. So one of the recommendations for them would be not to exercise, because exercise will induce the tachycardia. So pretty much, if you are having these fast beats, no matter how old you are, you should see a doctor, at least to be screened. And then if you are deemed low risk, then you have a choice of what to do.
Okay. So we've talked a lot about these fast heartbeats, and there's a whole other area of people feeling palpitations but actually having a slow heartbeat. Are their symptoms a little bit different than the people with a fast heartbeat?
Okay. I've had all kinds of descriptions. There are people who feel like they are missing beats, or they have extra beats, and they describe it as someone punching them in the chest, butterflies, water balloons, all kinds of different sensations. The extra beats, from my standpoint, the evaluation is very similar. You talk to me, we discuss what your risks are for heart problems. You need to have the EKG, the ultrasound, and those, similarly to the fast beats, most of them are benign. I find that most of them in older people, they're associated with high blood pressure. So those extra beats, most often we can treat with medications. But the workup, the evaluation is very similar.
Okay, good. What about, you mentioned the athletes. So if an athlete says, gee, I was running a race and I got really bad palpitations and then I felt faint. I didn't pass out, but I felt faint. How would you evaluate that type of person?
Okay, excellent question. So athletes, young, healthy, buffed up, in good shape, those are the worst for a physician and for parents, for coaches. It's the worst thing when something bad happens.
Right.
So you want to be, you don't want to blow them off. If they have symptoms, any of those symptoms you described, exercise-induced chest pain, shortness of breath out of proportion to what usually you're supposed to have, fainting spells, any kind of that, it should raise an antenna that they should be evaluated. In Italy, all students and all athletes are screened by a cardiologist.
Right.
And so the reason for that is that there are rare congenital problems or some genetic problems that predispose to suddenly dying during exercise. And so if you have that and you know about it, you can prevent it. Hence the fact, so in the United States, we don't routinely screen athletes, but if they have any symptoms, they should be evaluated.
What would your screening for the athlete be? What testing would you recommend?
EKG, and if they have symptoms, any symptoms, an echocardiogram. In Italy, everybody gets an EKG. If you have a symptom that one of the symptoms you described, then an echocardiogram, the ultrasound, to look for heart function and so forth.
Yeah, for these athletes who come to my office and they tell me they have those symptoms when they're active, I often try to reproduce that situation by having them go on a treadmill.
That's an excellent idea. Yes.
And to see what happens.
But I don't want I don't want the audience to be worried. What ends up happening is that if you're an athlete and you have any of those symptoms, most often it's benign.
Mm-hmm.
It's from dehydration and so forth. But you don't want to guess. You rule out the dangerous things, and the diagnosis of exclusion is dehydration and heat and so forth.
Right. I think in the U.S., I think one of the leading causes of that problem is this thing called hypertrophic cardiomyopathy, where the heart muscle gets unusually thick and just doesn't function efficiently when you're really going at high speed. And I think the other one that I want to get your opinion on, and we're getting very, very technical here, but there's a problem with what's called the right ventricle of the heart, which is the chamber that pumps blood to the lungs. And sometimes athletes or anyone can have a right ventricle that's not working right and prone to rhythm disturbance. Can you just say a word about that? I know this is getting into maybe a little more technical than we had intended, but it's an interesting topic.
Both of those things you described, they are genetic, and they're genetic. They're actually the patient, they're born with it, but they present at an older age, in the adolescent age or older. And people can live normal lives without knowing them. So, and the presenting symptom is oftentimes fainting or shortness of breath. And from the audience standpoint, from our standpoint anyways, it's the same, the echocardiogram and the EKG and so forth. But the right ventricular dysplasia, if we are worried about that, then we also can send the patients for cardiac MRI.
Mm-hmm. Let me ask you some more questions about ablation, because we've talked about the ablation procedure, but can you explain to us a little bit about how it's done and how long it takes and whether there's any dangers associated with that?
Okay. I start telling the patients, whenever we are in the heart with catheters, there is a risk of something. But it ends up being that the risk is small. Less than 1% of the time there's any complications.
Mm-hmm.
So
that's a good number, less than 1%.
The patients who come to us, we tell them, come in the morning to one of the local hospitals that they have the equipment for it. And it's a day procedure. You come in the morning, you go home in the afternoon.
Mm-hmm.
And you don't even need general anesthesia. It's sedation. It's with medications to make you sleepy, but not completely out. Not on respirators, not anesthesia. And some patients even remember the treatment, although some may forget it. Mm-hmm. It's the same medications you may have with a colonoscopy. It makes you forget it a little bit. Right. So it's not a surgery. It's the whole procedure is done through catheters. And how the catheters go into the heart is through a blood vessel in the groin area, through the needle stick. And the needle stick hole plugs up in a few hours. When you remove the needle, it plugs up, and by the afternoon, when the time comes to go home, you walk home. And usually I tell the patients they can go back to school or work in a few days. And how we know where the catheters are in the heart, we use an X-ray machine. Mm-hmm. And how do we map the electricity of the heart is these catheters have wires in them. And with the wires, we map the electrical activation of the heart. When we map it, we know where the short circuits are. And when we determine where those are, one of those catheters, the tip heats up. And we can zap, quote unquote, the scientific name for it is ablate, that area that's causing the problem. And 80 to 90% of the time, whatever that fast heartbeat was from, it's permanently cured with the ablation.
And how long does that take? Well, let me more specifically. So, if someone has one of these common rhythm problems, you said a nodal problem from the middle of the heart. So, what would be the average time an ablation would take for something like that?
Well, the actual ablation, the heating up of the catheter, 1 minute. But the procedure takes longer because you have to first map the fast beat and figure out what's going on. And that part is the hardest part. to map the electrical activation of the heart. That the overall, how long you are in the lab, that operating room, usually 2 hours.
Okay. Well, that doesn't sound like it's too long. I mean, not
Right.
And plus, the patient's sedated, so they're very relaxed during that whole time.
Yes. Oftentimes we come out and they don't remember if we even started. So that's the common things. Oops.
Well, that's great. I mean, this has been a terrific summary from Dr. Pourati about how to evaluate palpitations. We've talked about a lot of the types of patients who might come in and seek your help with different types of palpitations and procedures you might do, and how you determine whether it's a rhythm problem they need to be very concerned about, or whether it's something they can have just a mild form of treatment for. So I think that's been very, very helpful for our listeners.
Thank you very much. Thanks for having me.
Oh, you're welcome. So this has been another segment of Matters of the Heart. I'm Dr. Kenneth Adams. I've been speaking with Dr. Isaac Pourati, our electrophysiologist, about how to evaluate palpitations. And thank you very much.
Thank you.